Hello and welcome to the topic Primary Sclerosing Cholangitis in the module Gastroenterology and Hepatology. By the end of this topic, you should be able to define primary sclerosing cholangitis, explain the pathophysiology of primary sclerosing cholangitis, describe the clinical presentation of primary sclerosing cholangitis, outline the investigations in the diagnosis of primary sclerosing cholangitis, and finally, discuss the management of primary sclerosing cholangitis. Let's get started. Primary sclerosing cholangitis, or PSC, is defined as inflammation and scarring of the bile ducts, which normally allow bile to drain from the gallbladder. It is characterized by the inflammation of the bile ducts or cholangitis with consequent stricturing and hardening or sclerosis of these ducts due to scar formation, be it inside and or outside the liver. The resulting scarring of the bile ducts obstructs the flow of bile, which further perpetuates bile duct and liver injury. Chronic impairment of the bile flow due to blockage and dysfunctional bile transport causes progressive biliary fibrosis and ultimately biliary cirrhosis and liver failure. The primary physiological function of bile is to assist in the breakdown and absorption of fat in the intestinal tract. A relative deficiency of bile can lead to fat malabsorption and deficiencies of fat-soluble vitamins such as A, D, E, and K. Liver enlargement is seen due to portal hypertension caused by compression of portal veins by the proximate sclerosed intrahepatic bile ducts and leads to right upper quadrant abdominal pain. The exact cause of primary sclerosing cholangitis is unknown and its pathogenesis is poorly understood. Although primary sclerosing cholangitis is thought to be caused by autoimmune diseases, it does not demonstrate a clear response to immunosuppressants. Data have provided novel insights suggesting an important association between intestinal microbiota and primary sclerosing cholangitis, which is a process referred to as a cellular senescence, and the senescence associated with secretory phenotype in the pathogenesis of this condition. Among the symptoms or clinical manifestations you want to look out for are reported as fatigue, pruritus. One would complain of having yellowish discoloration of the skin or jaundice, pain, fever, as well as weight loss. Nearly half of the people with primary sclerosing cholangitis do not have symptoms and are often incidentally discovered to have PSC due to abnormal liver function tests. But a substantial proportion of them will have debilitating signs and symptoms of the disease. So you want to look out for, as mentioned earlier, any evidence of jaundice, abdominal pain, evidence of cholestatic jaundice, particularly where the patient would be complaining of having dark urine, fatty stool, pale-colored stools, esophageal or peristomal varices, enlargement of the liver and spleen, abdominal pain, and hepatic encephalopathy. So you look out for signs of chronic liver disease as well as evidence of portal hypertension. So symptoms consistent with these entities include variceal bleeding, ascites, and hepatic encephalopathy. Cholangiocarcinoma or manifestations of portal hypertension in advanced stages of liver disease can be looked out for also. Now, when we look at lab investigations, the first step is to screen patients for PSC by doing a blood test. In PSC, liver tests should be evaluated. Specifically, the liver blood test called alkaline phosphatase is often abnormal, though a small percent of patients with PSC may have normal levels. A cholestatic picture of liver function with elevations in serum alkaline phosphatase values are the biochemical hallmarks of PSC. Increases between 3 to 10 times the upper limit of normal occur in 95% of cases. Serum alanine and aspartate aminotransferase ALT or ASTs are usually 2 to 3-fold higher than normal levels. The serum total bilirubin level is normal in 60% of individuals at diagnosis. The most common characteristic histologic feature is onion skin fibrosis, and this is seen in liver biopsy. When it comes to imaging studies, An MRCP, which is a magnetic resonance cholangiopancreatography, uses the MRI images of the liver and the bile ducts and is the test of choice to diagnose primary sclerosing cholangitis. Percutaneous transhepatic cholangiography or PTC and endoscopic retrograde cholangiopancreatography or ERCP may also be utilized, more for therapeutic intent rather than diagnosis. So ERCP and specialized techniques may also be needed to help distinguish between a benign PSC stricture and a bile duct cancer or cholangiocarcinoma. So there's no pharmacological treatment that has been approved by the FDA for PSC. However, some experts recommend a trial of ursodeoxycholic acid or UDCA, a bile acid occurring naturally in small quantities in humans and has been shown to lower elevated liver enzyme numbers in patients with PSC. Supportive treatment for PSC is the cornerstone of management. These therapies are aimed at relieving symptoms such as itching with antipruritics, antibiotics to treat episodes of ascending cholangitis, and vitamin supplements as people with PSC are often deficient in fat-soluble vitamins like A, D, E, and K. Liver transplant is the only proven long-term treatment for PSC. Indications for transplant include recurrent bacterial ascending cholangitis, decompensated cirrhosis, hepatocellular carcinoma, hilar cholangiocarcinoma, and complications of portal hypertension. The reasons why a subset of patients develop recurrence in PSC remains largely obscure, but surprisingly, those without recurrence of disease are characterized by an increased presence of the potentially pathogenic gamma proteobacteria Shigella. A liver biopsy can help determine the extent of damage to the liver. The test is used only when the diagnosis of primary sclerosing cholangitis is still uncertain after less invasive tests are done. A liver biopsy is a procedure to remove a small piece of liver tissue so it can be examined under a microscope for signs of damage or disease. Liver transplant for patients with advanced cirrhosis is advocated. So over the past decade, the outcome of liver transplantation in primary sclerosing cholangitis patients with end-stage liver disease has improved significantly, with many centers reporting a 1-year patient and graft survival of 90 to 97% and 85 to 88% respectively. So to summarize, we have looked at what is primary sclerosing cholangitis. It's the inflammation and the scarring of the bile ducts. And we have looked at the causes and pathophysiology, even though not very clearly understood yet. We have seen the clinical manifestations, investigations, and surgical as well as medical approach in the treatment of primary sclerosing cholangitis. We have come to the end of this topic. Thank you for your time.